And then I'm going to make Barry, let's make Barry a host. Make host. So thanks guys very much for joining us today. I think this will be a very useful talk and reminder about clinical notes and what stuff we need to put in. I think the key thing is keep yourselves safe. We are extremely lucky. We've never had a physio hauled up in front of an HCPC council, and I don't want anyone here to be the first. And we deliver a lot of appointments. We also have very, very low complaint numbers, which is really, really good. I guess we probably have less than 8 or maybe 10 or 12 complaints a year. So it's extraordinarily low. And I think one of the reasons is that we try and keep everyone safe. If we stay safe, one of the best ways to stay safe is to make accurate clinical notes. So on that note, I'm going to hand you over to a brilliant osteopath, and he's going to be a lead for us as well with regards to supervision and support and mentoring. Barry, you can tell us a little bit more about your experience, but we all know him as Uncle Barry. Over to you, Uncle Barry.
That's great, thanks, Tim. Uncle Bulgaria or Uncle Barry both work. I've got a slide actually with my experience, but we're going to send an email out shortly, because one of the things I'm going to be doing is providing mentoring, which is not being reported to anyone, is totally anonymous. If people have questions, whether they're clinical, practical, even personal, if you contact me, we'll either chat on the phone or I'll come and see you. And anything that we discuss and everything, except for safety issues, but everything will be totally anonymous. I don't report to anyone, and it's an opportunity for people to get support across the board. So that's really, really important. So yeah, I'm just going to share my screen.
Even if there are safety issues, you know, I mean, if it's, I don't actually want to know anything that you talk to Barry about, or none of the team do. So I want you to feel like you're in a safe space with everything you talk to Barry about. So if there's any worries, no question is too silly. No question is too stupid, and you know, if there's gaps, we can work on and we can support you. But we want you to know there's a safe space for you to talk to someone when you don't know pathways, when you don't know, and you don't want to post it on a group for whatever reason. It's fine. PM Barry, message Uncle Barry, and say, "Can I have a chat? Can I just ask you this question?"
And yeah, unless you support Tottenham Hotspur, in which case we have a real problem. But Luke will always manage to bring that into a conversation. So I believe it or not, I'm quite passionate about notes. When people say things like that, you probably worry, but if it's not in your notes, it didn't happen. And I'm going to talk more about that. But as Tim said, we just got to be safe practitioners. And ultimately, and unfortunately, most of the cases that come in front of me, and I sit on the Professional Conduct Committee of the General Osteopathic Council, your only defence is going to be your notes, because it always comes down to he said, she said. And I don't want you to think that all I'm going to be talking about is doom and gloom tonight, because I'm going to talk about best practice, and I don't want us to worry too much about complaints, but they can happen, they do happen. And the more comprehensive and the more detailed your notes are, then the more likely you are to, you know, have a good defense. So my background, apart from being Uncle Barry, is I was a solicitor in private practice for 8 years before I trained as an osteopath. I hated everything about being a lawyer, apart from the pay, which was very good. And my legal practice was commercial property, which has absolutely nothing to do with anything useful for us tonight, but that's my background as a lawyer. I've been on the Professional Conduct Committee for, this is my 5th year out of, I think, 8. I'll do another 3 years. And I sit on hearings from everything to do with practitioners working without insurance to sexual misconduct and everything in between, everything from a half-day hearing to a 10-day hearing. So if you can think of anything, I've seen it. I didn't hear that. What was that? Oh, I don't know if that was Tim, did I miss an important question?
No, I'm
No.
just going to try and figure out how to mute everyone.
Okay. If anyone does have questions or funny comments, then just put your hand up and I want to hear them. I've lectured in medico-legal ethics for over 10 years at 2 universities in the UK and around the world. And I am an Arsenal fan. I've just put that in for Luke, and I'm not Uncle Barry. That's also for Luke, but I am actually, it seems, Uncle Barry now, and I'm never going to escape that. So Uncle Barry it is. So EMIS is what we're going to use as FCPs, and I assume you're all pretty familiar with it. If you've done one clinic as an FCP, you've probably seen 12 patients. That's enough to know the system pretty well. And the tabs that I use when I use EMIS are problem, history, examination, comment. Rarely do I add anything else in there because everything can go into those tabs. And I'm going to tell you what I think should go into each of those tabs. And I think that the problem one, the first one, is nice and easy because it's what the patient comes in with. And hopefully your appointment book will say knee pain, and your temptation will to be write knee pain. And if you start writing knee pain and look for the coded knee pain, then you might come a cropper because you start taking your history and actually it's not really knee pain, it's back pain radiating to the knee. So whilst I bring up the problem box first, I don't always fill it out straight away. Right? I leave that to just make sure I know what the patient is presenting with. And I think that's really, really important. The doctor might have referred to you, or the receptionist might have sent the patient to us, and the patient said X, but actually their problem is Y. One thing you can do, and I try to avoid it as much as possible, is when patients come in with multiple problems, then you can open up a second problem and then, you know, a second active problem within EMIS. I try and get them back for a second appointment. And for those of you who may not be as long in the tooth as I am, and that includes Tim as well, when patients, you know, I had a young guy come in to see me last week and he was all smiles, and then he said, I've got 3 problems, and they were like totally unrelated, and he was about 5 minutes late. And I said to him, well, I can deal with one of them today, and then I'm going to book you in for a separate double appointment to see the other 2. And he went off on one. Blah, 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 you know, what are my other problems not important? And I said to him, look, the simple solution is this. I can look at one thing really well today, or I can look at 3 things really badly. And very quickly, he changed his mind. And at the end of it, he said to me, I'm really sorry, I went off on one. When can I come in next for the other? Could take seriously. So, you know, try not to be, in my opinion, try not to be dragged into dealing with truly multiple problems. And try to be as accurate as possible. Oh, Dan, you've got your hand up. Go for it.
Hey, Barry, how are you?
Yeah, good, thanks.
That's the way. If the GP codes say ACL tear, but it's in fact osteoarthritis or something completely different, what do you do with the coding?
So I change the coding to what I think is appropriate. So I always put my notes on my notes, and it's based on my clinical judgment. I don't trust the GP sent to me. They've said to me they've had an X-ray and they've got X. I've still got to make my own clinical judgment about what that is, and I code it appropriately. Is that right, Dan?
Okay, perfect. So you code it for yourself rather than just to follow.
100%.
Yeah,
100%.
100%.
I'm going to talk about. I'm going to talk about another issue with that in a second, but
Yeah,
it doesn't
perfect.
matter what the doctors put, what the receptions put. It doesn't matter what the patient tells you. There comes a point when you've made a clinical judgment about what's going on, and at that stage you can code it appropriately.
Yeah, perfect.
The difficulty with using the coded problems is that, you know, they don't always quite deal with, you know, they don't have I don't know, patellar tendinopathy. You know, that's what your diagnosis is. So you end up putting anterior knee pain, which is okay, but you want to be more specific. So when I come to the comment box, I'll tell you what I put in there. But, you know, it's never, EMIS is not perfect. It's great, but it's not perfect.
Yeah.
Sorry? Any questions on problem before I move on?
Untable style.
Barry, because you're host, can you mute Mustang?
Yeah, I don't know if I can do that. Here we go.
If you click participants, I think you might be able to do it from
No,
there.
it's just showing me. I think I can, because I'm sharing screen, it might not be so easy. Okay, I'm just going to leave it because when I press,
Yeah.
You're right. I was going to mute you, Tim. That would have been like real power. Oh, everyone's showing as muted on mine.
Do it, yeah.
No, everyone's muted. Everywhere. It's not me. Okay, we'll move on. Right, history. Now, history is it's the crux of it. And I tell my students when I was teaching at university, you can't move on to examination until you know what's wrong with your patient. And they always found that quite perplexing. But in my view, and there are papers on this that suggest that 70%, even 90% of diagnosis comes from your case history. So you've got to take a detailed enough case history to get to the point where you know what's going on with the patient. That's not always possible, but I would say 3 out of 4 patients, I've got a really good idea what's going on before I examine them. Obviously, I've come to my differential diagnoses in my mind, but of those differential diagnoses, I am pretty confident I know which one is going to be the final diagnosis. We've got to be a little bit careful with that. You know, we don't want to narrow it down too quickly, but that's our job as good clinicians who are triaging our patients. So you might use a model, some of you will be familiar with, some may not be so familiar, which is Socrates, which stands for site, onset, character, radiating, alleviating, time, exacerbating, and severity. I'm happy to put that somewhere else so you know what that is, but it's basically outlining all the different aspects of their pain to understand what is causing their pain. But not just for Tim, but for me, the two things always clearly state aggravating and relieving factors, right? They're going to be really diagnostic. And I put aggravating and relieving and then a colon, and then I list them. Always state no red flags when there are none. And it sounds obvious, but I think there's a temptation when someone comes in with back pain to say no red flags, but when they come in with elbow pain, not to say no red flags. But actually, you have to have ruled out red flags for that elbow. You want to know it's not fractured. You want to know it's not infected. These are red flags. So for every single consultation that I do, I write the words no red flags, unless of course there are red flags, when that's a whole different problem. In this part, you want to include, where appropriate, details of activities, daily living, normal exercise regimes, right? I think it's really good. How many times do they go to the gym? What do they do? Yoga? All of these things should go into our notes. And do they have goals? Do they want to get back to running? Do they want to walk to the shops for 10 minutes every day? And I think we should put those goals in as measurable goals. And obviously, you want to be as accurate as possible in terms of history. There are loads of other things which need to go into history, depending on the consultation. One is if you use language line, then you have to say use language line, which language, and try to record, I try to record the ID of the person who's doing the translation. You need to record if somebody else was in the room. The patient's daughter was there translating. A big bugbear of mine, and I'm sorry to moan about it, but is if you're covering someone else's clinic and using their EMIS login, you must write that you are doing the consultations for every single consultation. Somebody covered a clinic of mine and they didn't do that, and their notes were very different to mine. They were okay. They weren't brilliant, but they were okay. And I thought to myself, if the doctor looks at that and it's my name on the notes, then it doesn't look great for me. And I'm building a relationship with that GP practice. So you have to say consultation carried out by Barry Kleinberg, cover FCP. And I do that every single one that cover clinic. So there
Barry,
are
on that point, sorry to cut you off.
Yeah.
If for some reason that went to medico-legal problem, who's at fault there? Are you liable or not really? Because obviously you weren't there.
No, it would be.
I think,
it would be the fault of the person that wrote the notes and didn't put their
correct.
name on them.
But it creates an unnecessary mess,
Yeah.
in my opinion.
Yeah,
And
it's really sloppy. Yeah.
If you see my notes, I haven't brought any examples today. But if you see my notes, you'll see that I do what I say, and they're long, and there are lots of notes in there. And if somebody keeps a much shorter form of notes, then that's not great for me, personally, in my relationship with the GP. And you'd expect me to do that for you, and I'm more likely to do cover clinics for all of you than you are for me. But I think it's just good practice when you're doing a cover clinic to note that. If you do get your own login, then there's no problem. Any question on history?
You take social history as well in terms of occupation?
Yeah. Yes, I try to. I might put desk-based job, or the thing is, I'm a bit aware, and it's difficult, that there can be a lot of repetition on EMIS, right? The doctor's taken history last week and they've put all that stuff. And I don't want to just say as per doctor's notes and the date, but sometimes I do that. I think some social history, it depends on the patient. If you've got an older, isolated patient, I think that's really important to go in. If there's any mental health issues, that all goes in. If their occupation is directly relevant to their presentation, then it should definitely go in. Yeah, I think it's a case-by-case basis. My gut feeling is anything you talk about apart from football, religion, and politics should really go into that section, because it's a record of what you do. Okay, examination.
Can I just ask one quick question, Barry? Sorry.
Yeah.
Regarding the history and the red flags.
Yeah.
If you put no red flags, do I still need to write no, like saddle anesthesia, no bowel bladder issues, etc. on top of that, or can I just put no red flags as a short?
You have. Great question. In my opinion, you put as much detail as possible. I would write no pins and needles, no numbness, no ridiculous symptoms, no bowel and bladder changes, no saddle anesthesia. And then after all of that, I'd put no red flags, because I want it to be absolutely obvious to the GP or anyone else that, because if I didn't put no red flags, they wouldn't know that I was thinking red flags. And if I put no red flags, they might think there are other red flags as well, right? So I want to cover both bases. It's good, really good question.
Would you highlight yellow flags, like just draw comments of yellow flags if you're picking up on some sort of psychosocial issues? Or
yeah, so I don't write yellow flags or pink flags or blue flags. It's interesting, my training as an osteopath where I was trained, we only used really red flags, and then where I taught for the last 3 years, we had so many flags, I couldn't actually remember what they were. But, I will note those things in longhand. So I will talk about psychosocial issues. I had a patient in my private practice actually 2 weeks ago, had a massive conference coming up. She was organizing a hybrid conference, in person and online, and she was so stressed. She didn't strike me as a very stressed person, but I wrote in my notes that she was under a lot of pressure at work. And then in the next consultation, I wrote, conference was finished, no hitches, patient much more relaxed. So I think it builds a really good picture to put those things in, definitely. But the challenge, of course, is I'm teaching you tonight, or we're discussing tonight, all the things you've got to put in, you still only got 20 minutes. And I'm totally aware of how difficult that is. But, it's our only defense. So we've got to try. Okay, examination. The biggest failing I see in manual therapy is people do not record negative findings for everything. Right? You might say negative SLR because you think that's important, but let's say I do an active assessment of the lumbar spine. I will record flexion, I might write NAD, nothing abnormal detected, extension, slight pain, bilateral rotation, no pain, left side flexion painful at LS junction, right side flexion negative, right? So if you do a whole assessment, you've got to show that, because if you just do flexion painful and left SLR positive, and that's it, that might be enough. But then if I was looking, I would think, well, did you not check the other movements, and did you do the SLR on the other leg? Right, so you have to record negative findings. Please don't use shorthand. That you, and you know, in our world, we use all sorts of, I might use DTM, deep tissue massage, STT, soft tissue techniques. I don't know what you use. MOBs.
HEP. HEP
Yeah.
is the one the GPs always moan about, and they always ask me when I go to GP practices,
Yeah.
and I have meetings with them, and they get, the last thing they say is, "What does HEP mean?"
Yeah, it took me, Tim, I'm really embarrassed to say, I think it took me 3 months of reading other people's notes, and I finally worked it out, right? You know, and that was me, and I'm an experienced therapist. Don't use any shorthand that, you know, that they're probably not going to understand. Now, I haven't talked about telephone consultations, but they are tricky, especially for examination. I've done consultations where patients have said, I'm on a bus, and you can't exactly get them to do movements, or, you know, they've stepped out of an office. Try to get them to do whatever they can. You know, can you bend forward? Is it painful? Or ask them about doing certain activities. So you can replicate activities and say, when you put your shoes on, is that painful? If you reach up for something, you know, you've got your extension, and record it. So in examination, I will record, it was a telephone consultation, unable to carry out full examination, but X, Y, and Z. Now, those are really my take homes for examination. Any question? Don't forget, this is, I'm not talking tonight about how to do an examination. I'm really talking about recording your examination findings. Dan, is your hand still up because you want to ask another question?
Oh,
Keep
no,
it
sorry,
up.
I'll take it down.
Oh man, I was
Yeah.
missing your hand.
Oh yeah.
Okay.
Also, what happened? I do have a question. What happened to Arsenal last night?
Okay, so unfortunately your sound went really bad, and I can't understand a word that's going on. And I am no longer your Uncle Barry. Find someone else. Yeah. But fair dues. Unfortunately, I was at a funeral, and fortunately, I wasn't watching the match. So I got home. My son said to me, "Are you going to watch the match later? Don't bother." So he saved me that grief. But anyway, all right. So the last box in EMIS I use is the comment box, and this is exactly what mine looks like. I write clinical impression, colon, I write my working diagnosis. Here I try to give you know, what I would call a medical, you know, allopathic diagnosis that anyone would understand. We don't want to go too far off piste. You know, in osteopathic world we might talk about a facet joint irritation. In the physio world we might talk about a zygoapophyseal joint strain, or facet capsular strain. You know, I use non-specific mechanical low back pain because the GPs understand what that is. I'll use tendinopathies and, you know, all of the standard diagnosis which they hopefully will understand. This is being recorded, so I won't say anything about what they do and don't understand about MSK medicine. Thanks, Tim. After I've written my clinical impression, then I write step 1, step 2, step 3. Sometimes I have 4 steps, right? But the first step might be regular ice, use the gym, keep mobile. It's usually something which is just a general piece of advice that I've given them. Step 2 will always say invariably when I can, exercises, and I write in my notes, emailed and printed. I've started playing with attaching PDFs to my notes of the exercises. To be honest, it's a faff and it takes time, and I don't always have time. I think it is the gold standard. I don't know if other people do it for every SCP patient. I think it's a lot to ask, but I do put in there emailed and printed, or if the patient hasn't got email, which shocks me how often that's the case, I'll put texted, and I'll use Accurex to send them a link. Step 3 will be to review with SCP in 4 to 6 weeks. I always put if necessary. It might say, you know, in there, referred for X-ray to review by SCP after X-ray, referred back to GP for blood tests. It could be any number of different things that go in there. But the hope is that when the GP looks at my notes, when they see the patient next, they can look at my comment box and know, the patient might say, I want to come in for my back pain. And the idea is that the GP will see that I've said they should come in 4 weeks if necessary. So the GP can say to the patient, why don't you see Barry again in another 4 weeks as he planned? Right. So we're trying to not just see the patient, but stop the patient going back to the GP unnecessarily and keep them in our list. I also write in step 3 there, in case I'm not in the clinic, and I don't think it's enough to say to review with FCP in 4 to 6 weeks if necessary, because what is that review going to achieve? So I usually put another bracket in there saying MRI ? Injection ? Or progress exercises, so that if one of you is taking over my clinic in 4 weeks' time and you see the patient, you can see my notes, which are excellent, and but you can also see what my plan is going forward, and that's really important to have that. Any questions on comment? I don't know if people do this as a matter of course, but I think this is really good practice. It's what Tim showed me when he did onboarding with me, and I took it on board, and I just see that it works, and GPs like it. So any questions on comment?
Yeah, do you know what? I'll just say that there's few ways for a GP to rate the quality of the FCP. And one thing I've noticed is that GPs tend to rave about their FCPs, how great they are, based on like 2 or 3 factors. And one of them is how busy you are. So if you're fully booked, they think you're amazing, right? Which is crazy, I know. And the second thing they really rave about is good clinical notes. And they rate your quality because they often can't see you. They often can't talk to you. But when they see your patient notes, because patients will always come and see you, and then they'll go back to their GP and they see great notes, they'll rave about how good you are, because usually the GP notes are very, very brief. So we can set a brilliant example by writing good notes. And of course, it keeps you safe. And the STEP program, the management, the STEP, they love that STEP program. You put in your clinical impression. I think it's a disc herniation, which is compressing the sciatic nerve, causing sciatica. Step 1, exercises, advice on work posture, and use ice and heat to reduce pain. Step 2, exercise emailed and printed. Step 3, review of FCP in 4 to 6 weeks. And then the GP knows exactly, wow, that's great. Like Barry says, patient comes back 2 weeks later and GP says, it does clearly say that we'll review you in 4 to 6 weeks if things aren't getting better, but you need to try the exercises that have been emailed to you and printed for you. You need to try them, and this is why this now coordinates your care with the GP care. Does that make sense?
Yeah, perfect. Okay.
Barry, one question. Will you ever put next to your clinical impression, say like differential diagnosis or not? Or we just, in case, say 4 to 6 weeks, you forget that patient, you're like, oh, okay, maybe it isn't hip OA and it might be GTPS.
Yeah. So sometimes in clinical impression, I'll put, say, non-specific mechanical low back pain, but I might put in brackets disc bulge ? So I didn't really think it was clinically presenting as a disc bulge today, but it's important enough that if you see them instead of me down the line, that you know what my other differential is. I think that's absolutely right. Yeah. Like
example, like frozen shoulder, or is it just an acute rotator cuff related pain? Or
yeah. And then, by the way, talking about rotator cuff, I think it's really important that in your history, I write it in my history part at the end. I might say, explain to patient that it's going to take a long time for
prognosis.
Capsulitis, can't even say it. So I put my prognosis in. It probably should go in for all of them. I know that the General Osteopathic Council guidelines prognosis should go in. I know we all discuss them. Prognosis is not always easy, but I do try and put it in there. Yeah, it's good. And it does change depending on our differentials. So good point. Okay, last slide, I think. And I don't want to keep you all too late. So notes must be a complete record and taken contemporaneously. So if EMIS crashes and you handwrite your notes, which is reasonable, then when I write my notes later on in EMIS, I write in EMIS handwritten notes were taken contemporaneously and transferred to EMIS later, right? I put that in because I don't want anyone to think that I put them in, you know, with time stamps when you entered your notes. And if you do it a day later or 2 days later, it's not good. So if you do have to handwrite something because EMIS crashes, then it's good to put that in. I've talked about the second point there, someone else's login. Something which gets missed quite a lot is if you speak to GP or one of your colleagues, for example, you put a question on the WhatsApp and you have a really good discussion about it and some conclusions, then record that in EMIS, right? You might open up the consultation you had with the patient that morning and just put a note saying, discuss case with colleagues, agreed with management plan, or discussed with GP who asked to be referred for blood tests. But those discussions go to you being clinically safe and competent. So I think it's really useful to put that into your notes. It's not always something we do as a matter of course, but I do think it's very good practice. And finally, if in doubt, come to Uncle Barry. That sounds terrible. I can't believe I said that out loud. But seriously, I'm running a busy FCP list, and but if you contact me, I look at my phone after every patient. That's in case my kids are dying or my wife needs me desperately. So if you send me an urgent message, I will try and respond as quickly as possible. If you've got a question about not just notes, but how to do an examination, differential diagnosis, what your management plan should be, not coping with the workload, your time management's awful, all of that, I'm really here to help everyone with all of that. But I hope in the half hour we've had tonight, I've clarified some of the important issues around note taking, and I'm really happy to take any questions people have.
Do you, Barry, do you type notes as the patient speaks, or for a face-to-face, will you type away as they're chatting to you, or?
Yeah, I was very lucky. I mean, I've been doing this for probably longer than most of you, and the first system I worked on when I worked for a physio who had private practice software, PPS, which I still use in my private practice. So I have been using that forever, and I type. If a patient's getting emotional, I take my hands away. When students have got a really bad habit, and you're typing away, yes, thank you, and then the patient says, and my wife died of cancer last week, and you go, yeah, that's great. So it's very easy to look at the screen and be typing and forget there's a real person there. So I try to have, I'm just turning my seat round, I try to have my screen halfway towards my patient. It's not always easy in GP practices, and I'm making eye contact the whole time, right? So even though I'm pretty quick typing, even though I'm really old and I support Arsenal, I type with my fingers and some of my toes if necessary. So I'm pretty quick, but it's a challenge. My advice is to keep notes as you go on as much as possible. That might mean that you ask a few questions and then record some answers and then stop and then ask some questions. Everyone has to find their own way. There's no rule, but it's really hard to recall afterwards, and you create a time management problem if you're always typing up after appointments. Anyone else? I love Dan's voice. I love Tim's voice, and I certainly.
So I'm going to just share the clinical notes audit. So I don't know, has anyone here been through the clinical notes audit? But anyway, it's Barry has, yeah, probably a few of you have. Let me just share my screen so you can see that. Now here you have it. So it's really straightforward. First of all, like Barry said, is the problem coded, i.e. knee pain, assuming that it is knee pain, that can sometimes change. So you may have to change that later on in the history, or you might put that problem in later, but you need a coded problem like knee pain or hip pain or shoulder pain. History, so, mechanism, injury or onset, duration, any aggravating relieving factors, any social history, occupational history, and obviously red flag questions. Gold standard is, as Jeremy alluded to, gold standard would be to rule out negative red flag questions. So, no saddle anesthesia, no bowel and bladder disturbance, no loss of sexual function, no bilateral leg pain. And I think the key ones to do are when there's potentially, I mean, it's good practice to do it all the time, but definitely do it for sort of neurological issues. And then you've got your examinations, so observation, general examination and special tests. I tend to just put 3 things down in examination. So I'll put down active movements or passive movements or observation or, or a special test. And then your clinical impression and your stepped approach. And it really is straightforward. It's as easy as that. They don't have to be overly long. They don't have to be overly onerous. You just have to get the basics on there. And if you do that, you're doing it right and you're covering yourself. And there's only just one last thing I'd add to that as well. Just mention if you've safety netted the patient. So let's say the patient does have bilateral leg pain, but you're pretty sure it's not an urgent requirement to go to court requirement, urgent requirement to go to A&E, then you might just put safety netted patient, advised that if they have any loss of change of bowel or bladder disturbance or, then I've safety netted patient and advise them to go straight to A&E. So just put that down just to cover your back in case their symptoms get worse. It's rare, of course it's rare, but just cover yourselves. Does that make sense?
Thanks for that, Tim. I just want to say I completely forgot, but when I write no red flags, I always write safety netted. And I do safety net. You can't just write it, by the way, people. You actually have to do it. It's really important. And you'll see actually the GPs write that all the time because it's very much a case of that makes you a safe practitioner. Thanks, Tim. I'm happy, as I say, I'm happy to take any questions, or if anyone wants to ping me on WhatsApp or make time for me to come. I'm really happy, by the way, my diary permitting, to come and observe. Even if it's just a couple of patients, if I've got the time, I'll come and watch you in clinic, not critically, to teach, to give you, critical feedback. And it is totally between you and me. So if I were you, I'd take this opportunity. It's a great opportunity. We can talk about Arsenal, which is not such a great opportunity. And, and you can buy me a coffee and it'll be fantastic. If no one's got any questions, thank you. Really, thank you all for coming. Tuesday evening at 7 o'clock on a wet and windy December evening is not fun. So I really appreciate it and hope it was of some use.
Thanks, Barry. That was great.
Absolutely brilliant, Barry. You just nailed it. Thanks so much.
Good night, everyone.
Thanks, Barry.